Thank you, Dr. Shabazz, and welcome, fellow dentists. So, as she mentioned, tonight's program is on medical consequences of periodontal diseases. I think everyone knows that it's been in the news for 2 years, the COVID. And the Journal of Dentistry just in December, in October, published that the transmission rate of SARS in dental settings was very low for both patients and dentists. And you all probably already know this. I know the American Dental Association president at the time, for several months, was saying there has been no documented evidence of transmission in the dental environment. So we have come out looking stellar in the field. We've done a great job, I think, in this. Has anyone heard of Novid? Yes.
Is that asymptomatic?
It's someone who hasn't had COVID. And I have Novid. I've never had COVID that I know of. And I wonder, well, I'm a periodontist, and I think in the future they're going to find also that periodontal diseases are correlated with COVID in the same mechanisms that we're going to show tonight. So, as Dr. Shabazz mentioned, I went to the Ohio State University. Did anyone go to Ohio State? Okay. Nah. Okay, Boston, I know somebody did their prosthetic and perio training at Boston. They have a very good perio-pros program.
That's Dr. Craighead, he's not here.
He's not here. All right, so, but what you did?
I taught at Ohio.
Oh, you did? Okay. Awesome.
From 1979 to 81.
Okay. What class?
I was there with the general practice dentistry program.
Okay.
The first one they set up there, I went there to set up.
Oh, all right. Well, I just missed you. So, all righty. Great. All right. And then I did my implant training while I was up in Boston at Harvard. I don't know if anybody took the courses there for the implant training. And then when I came to Florida, one of my mentors, Sam Lau, recommended to go to Pankey Institute. And I believe some of you here raise a hand who's gone to Pankey Institute. Awesome. All right, and it's great. It's you know, if you want to, they're wonderful. As a periodontist learning about inclusion, loved it. And Who's Who of Dentistry was right there. So we're going to talk about medical complications caused by periodontal infections, diseases that are highly correlated with periodontal infections, treatments for periodontal disease intertwined with medical conditions, how to train your team to support getting periodontal treatments, using the information in the motivational form we have on your table tonight, and patient education and motivation, because it's very difficult to motivate periodontal patients to go through with treatments. Or does anybody find it difficult, or was it just me when I started practice? Or is it, everybody's pretty good at it? Okay, no, okay, see, different heads shake around. So, medical complications caused by periodontal infection are heart attacks and thrombotic strokes. And the mechanism is inflammation in the cells, in the cellular structure, creating cytokines. The tissues create cytokines which go throughout the bloodstream, go to the liver, and then C-reactive protein is produced. And this is the key thing. Has anyone heard of that? C-reactive, everyone's heard of that, good. So, this is just an example of the blood supply, typical blood supply in a dental environment, the pulp on one side, and then the periodontal condition. And there's a rich blood supply where bacteria can just go in, the hemoplastic marrow, one with the bloodstream. So with the infection or inflammation, inflammatory cytokines are produced, interleukin 1B, interleukin 2, interleukin 4, and tumor necrosis factor alpha. Processed by the liver, and the liver produces C-reactive protein. Then the liver has a cascade, the C-reactive protein, when it gets on site to a certain area, like a arteriosclerotic plaque or a cancer, beginning cancer plaque, certain things begin to happen. Monocytes start to go to that area. There's monocyte CFS, interleukin 8, monocyte CP1. The second thing out of the four things, a decrease in plasminogen activator activity in human aortic endothelial cells. And the plasminogen activator helps keep the blood from coagulating. And so if that is decreased, there is a increase in the probability of a thrombus forming. And so when somebody has a thrombus and goes into the hospital, they give the TPA to break up the clot if their cells are not producing enough of it themselves. So that decrease increases interleukin 1 and tumor necrosis factor is produced. The third thing out of the four that happen are pro-inflammatory and pro-atherosclerotic activation of nuclear factor alpha B. And then fourth, this is just a diagram of a vascular cell. The vascular smooth muscle around the cell and the pathogenesis of the inflammation and arteriosclerosis via the activation of MAPK, ERL, the Jun N-terminal kinase, and P38 MAP kinase. So there's a lot of cellular mediators involved, but ultimately, when this clot forms through the sclerotic tissue, this vessel closes, and then a heart attack happens. So that's the direct mechanism. And it wasn't until recently that through genetic mapping and at the autopsy, they could find that the bacteria that were found in the necrotic cores of the arteriosclerosis plaques were the very same bacteria that were in periodontal pockets. So they were finally able, just very recently, to find a direct cause and effect relationship. So this is just another schematic of how that happens. Does anybody have any questions about that? Or it's also helpful to help your staff understand that, because some people don't make the connection or really believe it's a big deal. I could say that the periodontists might have had this experience in their practice, where I've had cardiologists in my practice for 30 years, and back in the day, they would just roll their eyeballs back when you talked about antibiotics and right, and you're like, no, there's really, there's a high correlation, just as high as smoking, of heart attacks and periodontal disease. They're like, yeah, you guys are just trying to build your own business. I can tell you, these same cardiologists would come in and they want antibiotics before they're having their teeth cleaned now. They don't meet the standard of care for antibiotics, but they want them. They go, I know better, I want them. And so those are my cardiologists, just saying. So here's the tooth, the disease, the periodontal disease. Then there's the direct and the indirect. The direct is the actual bacteria, and then the indirect are products of the bacteria, mainly the lipopolysaccharide coating that's around the bacteria, and then cytokines are activated by that lipopolysaccharide coating of the bacteria. And then it gets into the bloodstream. Here's the arteriosclerotic plaque, the big picture of it. And when the tissues start to degenerate around the endothelial, the vessel, a necrotic core happens. And it's this core that ultimately forms the clot that leads to the stroke. The endothelial junctions, remember those hemidesmosomal attachments and these tight junctions start to loosen up, and the low density lipoproteins can get through, and then the cytokines and the inflammatory mediators start within the tissues, and it forms the arteriosclerosis, and that's the mechanism of the low density lipoproteins. Then here's the platelets. They bump along, there's not a laminar blood flow. They start to then further enhance the clot. Here's the monocytes that turn into macrophages to destroy these, the diseased area, but the breakdown is faster than the healing. Sometimes, hopefully then it heals. Like this is all reversible, right? If you go on a omega-3 diet and try and enhance that, you can hopefully improve your health too. Good. Any questions about that? If anybody has any questions, just stop and we'll, just in the middle. I know nobody's ever seen anything like this in their practice, but has anyone ever noticed that when you have a patient like this and you do the 3 quadrants of scaling and root planing, and then the 4th quadrant gets better all by itself? Has anyone ever noticed that? That's in a healthy patient. But yeah, like you'll go back and you have the edematous tissue and the purple and the flabby, shiny tissue, and then you do the 3 quadrants and you get to the 4th quadrant and that's all gone. The calculus deposits are there, but it's gone. What is going on? Well, the C-reactive protein, the inflammatory markers, the half-life is about 30 days. And so you might ask, well, why do I have Tom Brady on here? Because I stalk. What? I stalk him. I just want to. No, but seriously. So I think everyone knows that Tom, he lives down the street on Davis Island. So just saying, I moved there to stalk him. But
Not alone.
yeah, okay, right. There's a lot of people out there. But the anti-inflammatory diet is what he ascribes his career to. In fact, you probably all have heard about that he's big on that anti-inflammatory diet. So why do we not test for this? Well, we could, but after the 3rd quadrant, it's probably just about gone. The C-reactive proteins now reduced, the inflammatory markers. The patient went from a spectrum of high inflammation down to low, by that time. So it's highly controllable, and so we do recommend getting your teeth cleaned, often, every 3 months. So we talked about medical complications that are actually caused by periodontal diseases, and now we're just going to talk about diseases that are highly correlated with periodontal infections. There's the cancer subset, preterm birth and low birth weight, Alzheimer's, respiratory tract infections, and insulin resistance diabetes. There's 700 bacterial species we know about in the oral cavity, and there's over 50% that that haven't even been cultivated yet. So we really just don't know that much yet. So how does cancer develop through bacterial and periodontal infections? First, the infection causes your local inflammation, like we saw with the macrophages and the cytokines. And once it disseminates into the circulation, it causes a systemic inflammation, and chronic inflammation is known to induce carcinogenesis. And I'll show, I have a schematic of that, how that happens. The inflammation response can be initiated by several types of pattern recognition receptors, of which the toll-like receptors are best characterized. And so that is an actual insertion of a change in the cellular DNA of molecules. Now we're getting into the cancer component. Toll-like receptors such as TLR, TOLR4 recognize microbial ligand lipopolysaccharides, which are derived from gram-negative bacteria such as Actinomycetes, which is the periodontal pathogen, the most well-known periodontal pathogen. And it transmits signals through myeloid differentiation factor 88 and TICAM1 pathways, leading to the activation of nuclear factor Kb, MAPKs, and other signaling pathways. So the receptors on the cells bring a component of the bacteria in and actually alter the DNA. So, and this is just one schematic of pancreatic cancer. You have the tumor environment with the endothelial cells, the tight junctions separating where cytokines can come in. There's inflammation from the oral mucosa. The immune system is suppressed. Obesity, basically people are eating a lot, okay, and that situation, maybe not all the right foods either. And then bacteria goes into the stomach, amazingly, can go through the stomach, go into the pancreas and into the intestines. And then you say to yourself, like, how can you survive the acids? How can this be possible? And we also know that Helicobacter pylori, a bacteria found in the stomach, is responsible for stomach cancers and ulcers. So, bacteria can promote oncogenesis, which is the beginning of cancer. In addition to inflammation, recent studies have revealed that bacteria promote oncogenesis by induction of innate and adaptive immune suppression. Sethi and others indicated that gut microbiome depletion by oral antibiotics causes significant increase in anti-tumor interferon secreting T cells with a concomitant reduction in pro-tumor and interleukin-10 secreting immune cells in the tumor microenvironment, resulting in a significantly reduced pancreatic tumor burden in multiple mouse models. So there's in that model, a direct cause and effect relationship of taking antibiotics. Colorectal cancers. All GI docs know there's a much higher incidence of polyps in people with periodontal disease, and these are some of the bacteria in the mouth found in colorectal polyps: Fusobacterium, Parvomonas micra, and Peptostreptococcus stomatitis. And here is a very similar pathology. You have your bacteria, you have fungi, you have the immunoglobulins, the antimicrobial peptides, a little mucus layer, the biofilm right here. It develops in the colorectal walls, pathogens. So the tooth surface, the barrier, the epithelial cells open up, cytokines develop, go throughout the bloodstream, and then inflammation happens, and then the carcinogenesis. And in the gut, wherever there's inflammation, there's a high incidence of polyps and then the polyps, there's a high incidence of them turning into cancer over time. Head and neck cancers, very similarly, you have the epithelium that it drops through when the epithelial cells lose their tight junctions. The periodontal pathogens get into the tissues. And then this is the oncogenesis, where they actually, the inflammation changes the cellular structure and changes the genetic nature and decreases apoptosis, which is the natural programmed death of each cell. So suddenly that cell doesn't die, it just keeps replicating. And then it's also producing factors that suppress other genes around it, suppressive genes. And that's how the cancers grow. Okay, so there you have the pathogenesis of cancers and a little bit of an understanding of that. Does anybody have any questions on that? So, all right. Yeah.
What do you tell your patients? I mean, how much of a relationship, now that we have a direct causal relationship research-wise, I mean, do you make a big deal out of that in your years of practice? Do you make a big deal out of that, telling them the periodontal disease potential for cancer without hesitation? You say that?
Well, on your desk, you have a form that we use in the intake form, okay? And so how we did it throughout our practice is they would circle the parts on here that concern them. And we would then, the assistant would go through all the intake form and hand them this, come brief me, I'd come back and go through this paper with them, all right? But whatever area in this, the big squares, I would look, there's basically 3 squares on the front and 4 squares on the back, or, whichever way and so then I would go, okay, if there were like 10 or 11 circles in that square, that category, so we have 7 categories of motivators that I know, okay, this is really what this patient wants to hear. This is why this person is here. So if they circled a lot with attractiveness, and I'll say we did a lot of, it was really fun to do a lot of cosmetics. So we had a lot of, I would say the majority of my practice was in the attractiveness spectrum. And so I would just spend all my time there. And I didn't really talk about oral cancers or too much unless they were smoking, a lot or drinking a lot. Of course we would want to do, recommend an oral cancer screening if their general, they weren't having one done at their restorative dentist. So I would really just see where they were here, but if they definitely put down heart problems, or if they were mostly on this side of the page, then we had tons of literature right there that they could read. And here, read this. I'm gonna go talk to the doctor. Let's bring her in. By that time, I kind of know, where to head. And they're very interested in listening to how this happens and how it happens and why grandma died and, those things.
Nicely done.
Pardon?
Very nicely done. I like this.
Yes, yeah. So that was, so that became a huge motivator because it's very, when I first started, it was like I was, as a periodontist, you're starving because you can't change people's behaviors. You can't change them. To get them to do something, they are sitting in your office for a reason, but to get them to understand that it's worth the investment and we can impact it. We can. It's hard for them to believe sometimes. So, and we'll definitely, I got when I was asking what people wanted to hear about, that was a component that I think, a lot of people, the first half of their practice want to hear about. So I definitely want to go into that. But this is a little bit of the pathogenesis of preterm birth weight babies. And it's kind of the same thing. They the tooth has the infection, the bacteria opens up the tight junctions, the bacteria and their components go, into the vessels, and then when it gets into the fetal placental unit, the bacteria can, in the same way, leak out and begin to inhabit the space surrounding the placenta, and then it induces preterm labor. Alzheimer's. Okay, well, there's no blood supply to the brain, right? It's cerebral spinal fluid. How did they find porphyria mortis there? So, well, guess what's inside of a tooth? A nerve. Guess what? The nerve has one cell dendrite that goes up to the cell body. and then you're at the cell body. You're in the ganglion, you're in the brain. And then here's the big, bigger part, same thing, platelets, the tight junctions open up, and then they find inflammation along the neuroinflammation, neurodegeneration, and cell death, and cognitive and behavioral alterations. So, similar pathology. And there was a big report that came out in January of 2020 that one of my medical specialty patients came in and gave it to me. And we were trying so hard to get his advanced periodontal disease under control. And he just sat down, he goes, I want to have my, scaling and root planning done. I want to have this disease removed. And it was just, well, it's about time, because that was his motivator. So respiratory diseases and respiratory cancer, we know, we went over the cancer. And diseases, I think this is interesting. So it's inhaled, right? The bacteria are inhaled, and normally the lungs are sterile. So how does an infection gain track? So there's the influenza virus when you're eating, or normally it's covered by a salivary pellicle. But guess what? When Porphyromonas gingivalis makes a little enzyme that breaks down the salivary pellicle, and then the virus is exposed and then can attach to the cellular membranes of the lungs and the bronchial tubes. So very interesting. Diabetes and insulin resistance. I think most everyone knows the relationship of periodontal disease and diabetes. You cannot treat periodontal disease if you don't treat the diabetes. So it used to be the HbA1c had to be 7. Now they've reduced it to 6.5, which I think is great. It probably could be even lower, but the closer you are to optimal, the better the bone and better things are going to heal. So we always try and take a patient from wherever they are and get them even more optimized, no matter where they are, even if they're 5.8, or let's get a 5.7. Let's get more optimized. So we went over diseases correlated with periodontal infections. We went over the cancer and the pathogenesis of cancers, preterm birth weights, Alzheimer's, respiratory infections, as well as head and neck cancers, and insulin resistance diabetes. Does anyone know what this is? I am taking you from the microbial world. So is anybody following the James Webb Telescope that was just launched a few months ago for the purpose of finding the beginning of the universe? Yes, it can see through infrared technology, and they pointed it to where the beginning of the universe has started. This is a picture of the beginning of what they believe to be the very first galaxy over 13 billion years ago. Isn't that crazy? And so these are the gases that will eventually, through gravitational forces and strong and weak nuclear forces and electromagnetic energy, turn into where we are today. And all these little microbes all come from that. I just think that is so amazing. Good. So I wanted to take you out there, and I'm going to bring you back here. So kind of get a little mind relief. So the medical consequences of periodontal disease, we are going to talk next about how your periodontal treatments are intertwined with medical conditions. So you need to get a detailed medical history. Just sit down and get every single medication that patient is taking, and then I basically coordinate the treatments with the doctor, get the blood work. A lot of times they haven't seen their doctor in a year, and they don't really have a doctor. And I'm like, well, let's just, why are you failing? Why did your doctor refer you here? Your treatments are not working out that well. Your implants are failing. Let's just, I do a little prescription, what I call my bone panel, and we'll get the HbA1c, we'll get the lipopolysaccharides, we'll get a lipid profile, we'll get CBC, we'll get vitamin D. And this is what actinomycetes looks like, Actinomycetes comatans. So this is the bacteria that lives in that little crevice. And it's anaerobic, by the way. When it hits air, it dies. It's also very difficult to cultivate. So we'll get the detailed medical history, the diabetes, we want to know the HbA1c, hepatitis. Are they going to clot? Maybe we'll need a INR, PT, PTT, vitamin D deficiencies. I had a 35-year-old in my office one time, just having such a difficult time with the extraction, the bone, the bone healing, the implant. It was just, what is going on? So finally, we sent her off. She had virtually no vitamin D. Her vitamin D was, so they put her on intensive vitamin D treatment. She was like osteoporotic at 35. It was pretty. So that happens. Renal disease. You might consider, if they're in end-stage renal disease, their calcium metabolism is going to be off, so they'll just need a higher glomerular filtration rate, above 20, I would say at least. High blood pressure. Has anyone heard how many Cuban refugees have come to Florida in the past month or so, or 2 months? 700,000. I know, it's mind-boggling. Yeah. Isn't that crazy? Yeah, so Governor DeSantis is sending them off to Martha's Vineyard, because we just can't take all those people, right? But I'll say this too, they're from a country where they might show up in your practice, and this was kind of common in my practice. If I had somebody from a South American country, or they're on first generation drugs, all right? So their blood pressure medication would be a non-selective beta blocker all the time, right? So you're like, whoa. I mean, I've not seen, in American patients, it's always a selective beta blocker. You just, you don't have to worry so much about unopposed alpha. And so then I'm thinking, if I didn't do a deep dive, I'm not familiar with this med because it's in a different language, but you want to know what that med is. I mean, they could have had scaling and replaning, we've given them epi, and then they're, dead on the floor. And then our legislators want to have dental therapists do this. It's bananas, I think. Does anybody think that's a great idea, or I don't know. I think I'm speaking to the choir. I'm not quite sure.
You're speaking on the choir.
That's
We all agree.
Yeah, okay. I'm like, I don't know what they're thinking of, but I guess they wouldn't have to send people off to Martha's Vineyard then. They would all be,
You're in safe.
take care. Just send them to dental therapists. You don't have to send them all the way up there, All right, so then lung disease, we talked about that, how that happens, and then hyperlipidemia. Now this is, I think, always kind of interesting, how the effluent breaks down the bone. And I don't know if anybody remembers, there was a mantra that you're always, with implants, you're just gonna get 1 millimeter of bone loss the first year, down to the first thread. Remember that? You get bone loss down to the first thread. And so you can kind of see how that would happen. Here's the little pumping action, a little bit of the abutment upon the implant. Actinomycetes are living right in here and just destroy the bone. And guess what? It stops at the first thread because that's the first platform switch. That's the first place where the bacteria stop, because they're bacteria, they're only like tiny, tiny little things, and they can't, it's harder to get past this place, and so now they just go up, go up. So that's why we do platform switching. So you sort of turn this circle into, you cut that in half, and all the bacteria just kind of go up. Does that make sense? Does everybody know about that? Okay, so that's why we do that, and that keeps the bone from being lost in that manner. And so these are kind of the older, you know, old-fashioned implants where you don't have the platform switching. This is the biologic whip, and all the periodontists kind of, you know, like I think we're always, you know, trained classically it's 3 millimeters, and you know, as periodontists we know could be anything. Could be 8 millimeters of connective tissue attachment. It could be anything, and that's all normal too and healthy as well. So the collagen fibers are circular. Create a little cuff, close it, and that's hopefully ideal. Another thing we want to know about are serotonin reuptake inhibitors. So if a patient is on serotonin reuptake inhibitors, we're beginning to see the tip of the iceberg where bone is not healing with those. And so if someone comes in, you can't tell them to, you know, just go off, but talk to their physician, maybe wean them off if you're having a problem. If you're not having a problem with bone healing, you know, but if you are, you want to present early on a backup plan. Like start talking to them, because you can't just, you know, cold turkey. So at least begin to introduce, we might be needing a backup plan. Talk to your doc about alternatives or ways to do that. And that is so prevalent. I don't know if it's, yeah, there's like suddenly everyone is on serotonin reuptake inhibitors. So we're gonna see something later on. All right. So we just talked about the medical consequences, and now we're into training our team. How do we talk about this? What does your team think? I know every once in a while, you know, I'll talk to staff, and they'll be, oh, this is just a way to boost your business, or this is, you know, they kind of think of doctors as self-serving, and you know, okay, they might be at some level, but we're trying to pay the bills too. But so depending on the team, you know, they might need a little help understanding all of these things that we just spoke about. And so what we did was we just had a staff meeting, you know, about once a month or once a week, or team huddle if we didn't have time for that. And we'd go over these forms and just say, you know, how did it go with those patients? And then we would just keep going over them. And does everybody know it takes about 8 weeks to build a habit? Or 8 times, 8 repetitions, does everybody know that? So you know, that's sort of like the magic number. We just kind of go over it about 8 times until people got very familiar with it. Patient education and motivation, we would have pamphlets, you know, in the reception area. A lot of times, people would come in with pamphlets. I had no idea that periodontal disease could cause heart attacks and strokes. And then they sit down and they're ready to go. They're already educated. I don't have to even spend a lot of time with them. We have pamphlets in the exam rooms. For my initial exam, we would keep them in there. The hygiene room, my hygienist was stellar. I had a goat staff, and we were talking about how to get a goat staff, which is Tom Brady for greatest of all time. Tom Brady language, just FYI. In the hygiene room. Then we had the like a little education loop in the reception area. And then in the new patient exam, we would spend an hour, because we were a relationship practice. We tried to get to know people and also identify their personal motivators. So we'll go through that. All right, so we went through team training, and then next we'll go through, so we talked about the staff meetings, the hygienist role. My hygienist played a big role. Basically, you know, we would do the scaling and replanning and curettage every 2 years, which I think is what insurance allows. We probably would have done it more if we could, or we do. I don't even want to imply that if they needed it, they got it. We didn't, you know, care what insurance reimbursed. If bleeding and pocketing isn't resolved within 3 months, then refer to a periodontist, okay? Because that means there's something more metabolic going on. It should be resolving. You know, that C-reactive protein should be gone. The assistant's role. Let me go back to hygiene, because we would give our hygienist an hour per patient, and they would spend the whole time educating them. They were very passionate about it. So we had that educational time reserved where they too could sit with them with a pamphlet, with you can get them free from Colgate. You can get all kinds of stuff. A lot of this you can get on the internet, download it, put it in a laminate, they can read it. And journal articles we would just have hanging around the office, depending on the patient. You know, a lot of people like a lot of detail, and they're very highly educated, and they want to read the journals. We have the 3D models, and then at the chair side, Google. We can Google something. So that was very helpful. So when we did the exam and found the personal motivator, we would find the motivator, which was in this category that we talked about, and then the next step was to find their personal motivator. So I would walk in with this piece of paper and say, oh, you know, it looks like, you know, 10 things are circled in the heart problems, not a lot in the other, so we would talk about that. And you would, let's just maybe ask, well, you know, what happened? You know, how do you, do you have this happening in you or your family? And, you know, they'll maybe say, you know, I had a grandmother who passed away from a tooth infection, and she had a heart attack or a stroke. So that's, you know, then you kind of know, well, right, well, this is why they're here. And if they don't schedule their next appointment, or if they, you know, lose their motivation, you just keep, you know, you can remind them, your receptionist can remind them a little bit. But once we found that personal motivator, we would write it top, front, and center, that anyone could very quickly identify what it is exactly personally to that person, not just the category, but that person, you know, this person's grandmother. And these motivators have different levels of, I guess you could call it like dental IQ or health IQ. Transmission to parent, spouse, or significant other. Usually that was grandparents transmitting it to kids. And then I would always say, you know, have you ever heard that your pets can transmit the same genotype of bacteria to family members? Has anyone ever heard that? That your pets can do that? Okay. And then we'd go one step further and just say, oh, by the way, do you have a beagle dog? Because as periodontists, we know, like, the beagle dog is the model for periodontal disease. And it's like, so if you have periodontal disease and you go home and you have a beagle dog, that dog is going to spread it to everyone else in your family, your kids, your grandkids. Everybody's going to get periodontal disease. So you have to bring them all in for treatments at the same time, committedly. And then I think, you know, then the attractiveness one, you know, you go over the attractiveness things. Social embarrassment, that falls into 2 categories. Are they embarrassed with their family, or are they embarrassed with others? You know, and try and find out.
I'm trying to find creative ways I could get periodontal disease from a beagle.
Well, the beagle licks your face.
Not
You
my
know,
face.
do you have a beagle dog?
I have a dog, but he doesn't lick my face.
Oh, okay, well.
What does he?
Oh, this went south real quick. Oh, right.
But that's.
It's moving right along. Okay, so. Man, everything else is gonna be anticlimactic after that. So, but I do wanna say that the motivator. So we're just eating off of the same forks and knives and everything. The pain and discomfort is probably the lowest of motivators. So somebody's circling in that category, I know they are of the bottom of, there is hardly anything that is gonna motivate them. And then the classic conversation is, what's the worst pain you ever had in your entire life? Like rank the pain you have right now. You're sitting in my chair because you're in pain. What is that? Oh, it's a 5. Okay, what's the worst pain you had? And it's like, oh my gosh, that was when I was in a motorcycle accident, and the motorcycle fell on my leg, and I was like, and I try and take them back to that place very slowly and just say, well, what happened? It's like, well, we made a left-hand turn, and the car ran into me, and then I woke up, and the motorcycle was on my leg, and what happened? It was burning, and what did it smell like? Just take them back to that place, and how much did it hurt? And you just let them experience that for as long as you possibly can. And then you can, later when they don't keep their next appointment, which is predictable, you can let them know how much pain this is gonna turn into. Like, man, you think that motorcycle accident was bad? This thing, when it breaks off and goes to your brain and kills you, you're gonna have the worst pain ever. And just try and use that as their motivator. And I can go on and on. And this is very interesting about how people make decisions. So people have made an emotional decision before they walk into your office, right? So the decisions are made emotionally, not cognitively. They're already made before they walk in. So there is, in technology, active MRIs where they can actually see the brain. I don't know if anybody's seen any of these TED Talks. See the brain. Now you know what I do. I sit home, watch the beginning of the universe, listen to neurology. So this is, and the active MRI can see what's lighting up in your brain. So they did this really cool study had a bunch of subjects sit there, and they said, okay, we're gonna watch what happens in your brain when this clock, second hand goes to 12, raise your right hand. So they have these subjects, and when the clock goes to 12, they raise their right hand, and they can see the activity in their brain. They see in the cognitive center a little message saying, okay, go raise your right hand, and then it goes to the motor center, and the hand raises, so they could see all that. So they took these same subjects, and they said, okay, now that we know what the motor center is, let's do another one where we stimulate the motor center and see what happens. So they said to these subjects, all right, now this time, when the clock goes to 12, raise your left hand. But they're gonna stimulate the right side because they know exactly where that right side is to raise the right hand. Has anybody heard this before? Oh, so cool. So guess what happens? The clock goes to 12, they stimulate the right hand in the motor center, and the right hand goes up. And they can see the electrical activity from the motor center to the cognitive center. Okay, so they see it going the other way. And each subject doesn't raise their left hand, they raise their right hand. The opposite of what they're told to do. Okay, so that's cool. So then now they know oh, we know exactly how to control the motor center, all right? So, in the third phase, they sit all these subjects down and they say, why did you raise your right hand when you were supposed to raise your left hand? And do you know what they all said? And remember that electrical impulse is going from the motor cortex to the prefrontal, where your cognitive, where you think, where you rationalize, where you make decisions. What do you think all those subjects said?
I did raise my left hand.
What's that?
They probably said I did raise my left hand. Is that
What
what they said?
they said is, I changed my mind. I changed my mind. And the investigators know, no, we stimulated the motor cortex. That's why you raised your right hand. We stimulated it. No, I changed my mind. I changed my mind. And that's why I raised it.
Interesting.
Isn't that crazy? Yeah. So this is who we're dealing with. You know, this is how we all actually are. We make these decisions throughout our life, and we don't even realize that we lead our lives these ways. So, just taking you out to the end of the universe. All right. So these are the other categories: the attractiveness, social embarrassment, family, transmitting it to family and others. That's a big one for dentures, for an implant practice. We would spend a lot of time in that arena. The new patient role, the intake, this is just a pathology slide of an implant that it's been cold welded in. You can see that. All the bacteria that's in here. Has anybody ever taken off an abutment and just smelled? You know, that can happen. And then this is the crevice. You can see all that space in there where bacteria can live. But the assistant can, you know, motivate them once they know their personal motivator, which is front and center in the chart. For tooth loss, dentures, and partial dentures, to segment, you know, we can get into that. You know, do you have eating difficulties? So if they spend a lot of time there, you know, what is it? Usually with that section, I'll take them back. Well, you know, did you ever have a family member without teeth? Or a family member that lost their teeth? And, you know, what's the earliest you can remember, let's say your grandmother, what's the earliest you can remember seeing them without teeth? And you take them back, well, I was 6 years old and they came home and they had just gotten their dentures. And then when they took it was heard when they took their teeth out, I was like, oh, yeah, I was horrified to see grandma with no teeth, just horrified. So here they are, 6 years old. I have taken them back. And that was a time where they made a decision in their life never to have that happen to them. So when they miss their appointments, and when they don't schedule, and when they keep the same behaviors that lead to a different conclusion than what they really want for themselves and why they came here, we can just remind them. So that is the patient education and motivation, and these rolls into the receptionist. Now the receptionist, they've canceled their appointment, they didn't make their next, maybe they walked out, they didn't make their next appointment. She's got their personal motivator. It's like, well, you know, when they don't make their appointment, it's like, well, I'd hate to see you in that time, you know, without teeth. You know, I thought you didn't want to be in that place. And we can just gently remind them, you know, why they came to see us in the first place. Good. In conclusion, this is just a case, my little epic case with 1 implant per tooth. This guy. So I can give you the long story and the short story, but it's just you know, an example of the platform switching implants and the restorations. This is what, you know. Good. he wanted to show off to his friends. So thank you very much. Does anybody have any questions? This is, as we alluded earlier, I had sold my practice and performed a 1031 exchange in December, because at that time, I was under the idea that it could, Biden was gonna axe all of those little tax benefits away. So I thought, well, if I don't do it now, is there gonna be a better time in 5 or 6 years? Is the market in South Tampa gonna be better? Probably not. Is our interest rates gonna be better? I don't know, probably, maybe. Yeah, not in the short term, for sure, not maybe 5 years, who knows, but, but I could, and so I worked with a fabulous banker, like this guy. When I heard that he's got 100% financing, it's like, that is totally amazing, totally amazing. I would be jumping all over that. So, but we did a 1031 exchange, got this commercial property, and now it's replaced my income that I was making from the dental practice. So that's what we're doing. And we're also acquiring investors, because guess what? You don't have to sell your building. They didn't repeal the 1031 exchange. You can just leverage off of it, and he's gonna give you 100% financing. So that's totally amazing. All right. So that's, you can get in touch with me there, that email, or this is my cell phone. So I moved out to, I got a little house on Treasure Island, watch the dolphin all day long. That's what I do. And visit the edge of the universe. Thank you.